And this is Dr. Patterson's contact information if you ever need to get in touch with him. With that, I'll hand it over to Dr. Patterson.
Yeah, so I've got a pretty straightforward presentation today. We've got some comments from after some of our other sessions, just asking a little bit more about opioid weaning protocols. And so I figured, I would put together a simple presentation discussing this and how you can help. Well, one, when to consider it, and then two, if you do start weaning your patient, what considerations you need to consider while weaning the patient to get the best results possible. Next slide. So overall, let's talk about what is the goal of weaning. Well, I think the goal is to see your patients at regular follow-up visits while prescribing opioids. And what you're trying to do is you're trying to determine, are the opioids the right thing for this patient? Do the benefits of them outweigh the risks? And what happens is that you may come to a point where you're finding out that the opioids are no longer helping the patient. They're not achieving the goals that you guys set, or you're finding out that higher doses isn't leading to more or less pain or improved function or a better quality of life. And so you get to a point where you decide that the risks don't outweigh the benefits, in that there should be a consideration at that time to either reduce the dose or consider just discontinuing them altogether. Next slide. So here are the situations that you should consider to taper. One, I've seen this, and I'm sure you guys have all seen that too, is that recently with the opioid epidemic and the spotlight on it that really happened kind of before the pandemic, and changes in Nevada law where AB 474 got enacted, you saw situations where either patients would talk to their primary care and they're like, look, these are out of my realm now. I can no longer prescribe you due to the new state laws. Or patients read an article about how accidental overdoses for being on these medications long term, or family members concerned that they're on them. I've had several patients come in and say, gal, I didn't realize what these medications, the risks associated with these. Can you put me on a lower dose, or let's try to discontinue them altogether? So I've seen patients actually request it, where that really didn't happen until the opioid epidemic really had a spotlight and the change in the laws. And God, I've even heard patients, after feeling like they went to the pharmacy and every month when they show up to get their pills, being questioned by the pharmacist, that the patients at that point were like, look, I just need to get off of these and kind of move on with life. Another scenario is that just like we're talking about, while you're following up with your patients and you're evaluating, are these medications working, you find that they just don't have any meaningful improvement. They're not getting pain reduction. They're not showing an improvement in their function. And so therefore, you and the patient decide that, hey, these aren't the best treatment for you. Let's try to discontinue them or wean down. Prior to the opioid epidemic, we saw that a lot of patients would end up on very high dose opioids. The belief used to be is that there was no ceiling. Patients could develop tolerance, and therefore you'd have to increase the dosage or how frequently the patient takes it in order to sustain pain relief. And so we got patients who are in the hundreds of morphine milligram equivalents per day. Now that we've seen the CDC guidelines come out in 2016 and get published, it's recommended that you try not to exceed greater than 50 morphine milligram equivalents. The worst case scenario, not to go above 90. And I think this is all based off of your overdose risk, less than 50 morphine milligram equivalents. You're only there is no safe dose, let's put it that way. But lower than 50 morphine milligram equivalents, your overdose risk greatly diminishes. Once you get over 50 morphine milligram equivalents, that risk increases by 2. Once you get over 90, that risk increases anywhere from 2 to 8 times more likely to have an accidental overdose. If you combine those with with a benzodiazepine, then you can actually times that by 4. So let's just say if a patient's over 90 morphine milligram equivalents, for example, they may be 8 times more likely to have an accidental overdose. Times that by 4 if they combine with a benzodiazepine. That means they're 32 times more likely to have an accidental overdose. And so it's recommended at this point that patients who are above 50 morphine milligram equivalents, just to reduce the risk, you should consider tapering them down, especially in the settings when they're on that benzodiazepine, because that greatly increases their risk. Hopefully that makes sense. There are other patients that as you're treating them, you're going to find that maybe your initial risk assessment, say with like a SOPAR or ORT, shows that they're low risk. But as you do reassessments every 3 to 6 months with, say, like a COM, you find out that the patient starts answering yes to more of the questions and they become more of a moderate to high risk. That would be, an indication to you that maybe they're developing an underlying substance use disorder. Or you see aberrant behavior by the patient. Now they're calling and asking for early refills. They're saying their medications got stolen, or an abnormal drug screen. They're seeing that a random drug screen is not consistent with what you're prescribing. And so you're starting to wonder if your patient developed a substance use disorder. And at that point, the best situation is to get them help and wean them off the meds. Other scenarios, which you hope don't happen, where a patient is on the medications, they develop an adverse drug reaction or an accidental overdose. That's a situation that you should reconsider what the patient's on and consider tapering them down or off the medication. And then the last situation is where patients show sign or warning signs that they're at risk of overdose. And that's where the patient shows up at your office. They seem to have confusion, sedation, and potentially even slurred speech. Next slide. But what you got to remember is not every single patient's the same. And so, a tapering plan should be individualized because every patient is going to be different. And the whole goal of the tapering should be to minimize the symptoms of withdrawals while maximizing pain treatment. And not maximizing pain treatment with opioids, but you're going to look at, other non-opioid medications or non-pharmaceutical therapies that can be used in conjunction with the opioid taper in order to give them pain relief and minimize their symptoms of withdrawal. Next slide. So I think the first thing that I want to preach is going slow. And basically the main recommendations for a tapering plan is that if a patient's been on opiates for greater than a year, you should go about 10% less per month. That's very reasonable. If, let's say, a patient's only been on pain medications for a few months or less than a year, then you may be able to taper them faster, and that you may be able to go by 10% a week and give them more of a rapid taper. But the biggest thing that you need to, to stress with your patient is that, hey, as we taper you down, if you consider, or, some patients may not like the fact that you're taping them, go see another physician, and they may just look at their board of pharmacy and say, well, God, he used to get, 6 Percocets, 10 a day, I'll just put you back at that, but the patient hasn't been on that. There's a risk of an overdose because the patients may have had some upregulation of their receptors with the taper. And now you go from a lower dosage back to that original dosage. There is a chance that the patient could have an overdose doing that. So you got to educate the patient on that as we taper you down, if at any point, we consider going back up or you see another physician and go up, we need to do it, gently and slowly. You just can't jump back up to what you were on before. That may put you at risk of an overdose. Next slide. So the other thing that you should consider while tapering is a consult. Is a consult necessary? Should you bring in another specialist? And so when I think of this, say the patient has abdominal pain, that you've been treating them with opiates for, should they see an abdominal pain specialist just to make sure that there's nothing else that can be done? Should they see a pain management specialist to look at the non-opioid or non-pharmacological options for the patient to help with their pain while you're tapering them down? If the patient had a substance use disorder, should they, while you're tapering them down, should they see an addiction specialist that can kind of a format that they can do some counseling and kind of encourage them through the process and provide you with support while you're tapering them down. It's not necessary. I think every patient's going to be different. You have to look at your situation. And if you think it's necessary, then, feel free to bring friends in. I always say that if a boat's going to sink, you want as many people on board as possible that can help out. Don't go down alone. The next thing that I want to, bring up is that there are high risk populations, right? So pregnant women, if you're going to wean them down, or if they're on opioids, they become pregnant, and you, the patient, and their OBGYN decide that it's best for them to minimize or get off these medications while the pregnancy is occurring before they give birth, that's a very high risk population. You got to be very careful with weaning those patients down. The next person is, like I said, somebody who developed a substance use disorder. I recommend, frequent visits with that individual. Now, if you're going to give them a taper, I can guarantee you, and you say, well, gal, you're on Percocet 10-325, and this month I want you to go down to 3 a day for 2 weeks, and then 2 a day for 2 weeks. And so you kind of do the math and you say, well, God, that's 3 pills a day for 14 days. That's 42 pills plus 2 a day for 2 weeks. That's 28. I'm going to give you 70 pills. I can guarantee you, they're going to struggle because they have an opioid use disorder. They're going to overtake those medications or continue to take them 4 times a day. And you're going to get a phone call, approximately 15, 16, 17 days later saying they're out and they need an early refill. So those patients I'd like to see on a weekly basis, give them only enough pills for that week, and consider drug screening at those visits as well too. But more frequent regulated visits with limited amount of pills can help out with those patients. And just as I was saying, you just need to use a lot of caution with pregnancy patients, and that's due to the risk, not only to the pregnant patient, but to the fetus. And that can be life-threatening for the fetus if the patient goes into full-blown withdrawal. So you got to be very, very careful there. Next slide. So support your patient. Make sure that they have adequate psychosocial support. You may want to bring the family into the appointments, talk with them. You may need to, once again, make a consult to a pain psychologist or a counselor to kind of help them through the weaning process to make sure that they have the support they need to succeed. If the patient's on higher doses, state law says that you should offer naloxone for patients on greater than 50 morphine milligram equivalents. And so naloxone is very important in those patients, or for the patients who developed a substance use disorder. You may want to make sure that they have naloxone on hand, make sure that they or their family members know how to utilize it. And then as you're tapering them, you need to watch for signs of anxiety, depression, or once again, as the opioid use disorder, and make the appropriate referral to treat those situations as needed. Next slide. And then encourage your patient. This is a team sport. You want to make sure that they know you're on their team and that you're there to help them out. So you want to promote collaboration. You want to promote buy-in from the patient. If they feel that you're invested with them and they invest into the plan, your success is going to skyrocket. And then you have to set expectations while you're tapering. And what you can tell them is that clinical studies do show that patients who do wean off these medications, even though they may experience increased pain initially, in the end, the patients who end up off or on lower doses have shown in these clinical studies that have improved function and decreased pain once the tapering has stabilized. So you may want to think about telling your patients things like, encouragement in them, like, I know you can do this, or, I'm going to stick with you as you go through this process. And like I said, I think that the best way to do that is to see them more frequently, not on a monthly basis, but see them at least every 1 to 2 weeks, so they know that you're there for them. Next slide. And then, through the process, you always want to continue to assess, adjust, and monitor the situation. So just like if a patient was on opioids and you're planning on having them long-term on chronic opioid therapy, you want to always weigh the benefits versus the risks in the situation. So as you're tapering them down, you got to continue to make that evaluation and determine what the best course of treatment is. So maybe the plan was initially to taper a patient all the way off. Well, if you minimize their dose and you find that they have improved pain and function and they don't feel like they can tolerate the taper any further and want to stay at that dosage, maybe you decide that you change your goal. You no longer want to wean them completely off. You can maintain a lower dosage. Maybe, like this time of year with the holidays, the patient's kind of struggling with the taper, but they've stuck with it. They're doing a good job. Maybe you stabilize the taper and leave them at a dosage to help them through Christmas. And then after Christmas and New Year's is over, maybe you restart the taper. So you don't have to, so even though the plan may be to taper every month, you can always stop it, reassess for a period of time, and then continue it when it becomes a better situation. You may find that a patient who's on 90 morphine milligram equivalents or higher, your goal is to get them under 50. You and the patient may decide that once they get under 50 that they're doing so well, the plan changes to taper them off completely. So you can always reassess the situation. You can always make adjustments, and then you can always determine how to best monitor the patient while you're doing that. And as a reminder, you want to avoid abruptly tapering or sudden discontinuation of opiates due to the withdrawals. Next slide. As I was kind of talking about earlier, you can adjust the rate, the duration of the taper. So if the goal is 3 months and a patient's struggling, you can take a break and make it 6 months. So always adjust to how the patient responds. You may find that a patient has very little side effects and wants to taper faster. You can always increase the taper as well too. But once you commit to something, you don't want to reverse it, right? If you and a patient made a goal that you're going to get to somewhere, stick with it. Don't back down and go back to where the patient was before. Like I said, just try to pause it temporarily, slow the taper down, and manage their withdrawal symptoms as best you can. And then once again, once the lowest available dose is reached, then you can extend the doses between the patient takes. And if the opioids are discontinued, then or consider stopping the opioids once you're on 1 dose per day at the end. That's when you can stop it. Next slide. And here are some resources. So some brief resources that I have for you. One is the CDC guidelines for prescribing opioids for chronic pain. Second one is the mobile app that you can use. And then another one is from the Mayo Clinic Proceedings. It's an article on long-term opioid tapering and chronic non-cancer pain. Next slide. That's it. I think I ended just on time looking at my clock. So any questions that any of you guys have regarding this? Any questions?
Yeah, please feel free to unmute yourselves or write into the chat box. Any questions, comments, anything that comes to your mind?
How often do you find that when you discuss tapering of narcotics and you actually prescribe lower doses, that patients suddenly want to make a change in physicians, or they protest a lot?
Oh, I mean, God, I can tell you, they're usually not very happy with it. But usually there's a reason. I mean, I can tell you there was one patient who Their physician lost their DEA license, and it was up in Susanville. The primary care doctor was giving the patient, and you probably won't believe this, 500 micrograms every 48 hours. So the patient was getting 75, 100 microgram fentanyl patches, and they're putting 5 on at a time and changing them every 2 days. The DEA came in and pulled his license, and the patients came down and said, "Oh, well, you're just going to continue this." And I'm like, I need a license too. This is my living. And if you think the DEA shut him down, do you think they're not going to shut me down for when you come down here? So, I mean, that they agreed to it, but every month the wife and the patient yelled at me incessantly. So yeah, you can get some very unhappy patients, especially if they've developed a substance use disorder and their goal is more pills, not less pills, and you're doing it in the best interest of the patient. Best chance for success is when the primary care backs us up. But I can tell you many times you're exactly right. I'll make the recommendation. I'll start the process. A month later, the patient doesn't show up. I'll look at the PMP, and I've seen that they've gone back to their primary care. And even though I've called the primary care in most cases or made sure that the note got faxed over their attention, they will pick it right back up where the patient left off. They'll put them right back at those doses. And if I even track them out farther, I usually see that they get sent to another provider to take over their care. So it's very frequent that I see that's both of those scenarios.